So as a headache specialist, I see a whole lot of different headache disorders. According to the International Headache Society, there's about 400 different types of headache disorders out there. But the most common ones that I treat are migraine, cluster headache, I treat paroxysmal hemicrania, but really the most important one, or the largest volume of headache disorders that I help take care of, is migraine. And largely because it's one of the most common headache disorders around. If we look at some epidemiologic studies, and I have a nice graphical slide demonstrating this, I wish I could show you, but if you look at populational studies, the numbers of migraine across the world are about 10 to 12% of the population experiences migraine. Here in America, that's about close to 40 million Americans suffering with headache. That's a lot of people. Ah, perfect. Great. Thank you. Yep. Beautiful slide there. So if we take a look at just the distribution across the world of migraine, we see about anywhere, it ranges from 1.5% in Hong Kong up to 32% of Peru, of people who suffer with migraine. But if we really focus in on Western civilizations, it's about 10 to 12% of the population. And here in America, that's over 40 million people. That's 1 in 4 households has at least one person suffering with migraine. It seems to be a disorder that seems to disproportionately affect women quite a bit more than men, and it affects people between the ages of 25 to 55 during our ages of peak productivity. So when we look at migraine in comparison to other headache or other disorders, it's far more common than both diabetes and asthma combined. Yet unfortunately it just doesn't get the attention that I really think it deserves. And hopefully that's the point of today's talk, is to help bring out a little bit more attention to what we think about migraine, what the science is, and help elevate the general understanding of what's going on. So according to a very recent study looking at the global burden of disease, migraine ranks in the top 10 most disabling disorders facing humanity. And the World Health Organization has reported that a day of severe migraine is as disabling as a day of quadriplegia. That's a very profound statement, because I think that migraine in and of itself is a very profound disorder. Migraine causes a lot of disability. It stops people from being able to participate in just household work. About over a third of people miss 1 to 4 days a month. Another 30% of patients miss about 1 to 4 days of just doing family activities. And about 15% of people miss work or school 1 day to 4 days a month because of their migraine conditions. We also know that migraine is a very costly disorder. It costs the average migraine person anywhere from $500 to $7,000 a year in losses. Part of this is because of medical costs, and not all of my images are coming up, but it's 70% of medical costs, or medical costs are 70% higher in a household with at least one person who has migraine. That's a considerable amount. Now, we also see that absenteeism is really quite high with migraine. Women lose about $1,200 a year, men lose about $700 a year because of lost wages due to their migraine. Now, I think it's really helpful in talking about migraine to really talk about what patients discuss with me when they see me. They tell me about a lot of their symptoms. And some of you might have migraine in the room, and you know what the pain is like. It is a moderate to severe pain. It is a throbbing pain. Oftentimes it's really worse with movement. Sometimes there's nausea and vomiting. Sometimes there's sensitivity to light, to sound, to smell. And there may or may not be things like aura associated with this. And that's a transient neurologic symptom, usually involving vision or sensation. We'll go over that in a little bit more detail. So by really talking about the symptoms, that really helps us inform a lot more about the neuroscience and neurobiology of what's going on. I think that's kind of a nice segue into finding out what really causes migraine pain. And for the longest time, we always thought that this is because of blood vessels, and it kind of makes sense in some regard. We know that blood vessels are very pain sensitive. If you have a tear in a blood vessel, or a clot in a blood vessel, or a spasm, that's an acutely painful thing. And some of the best medications that we have to use to treat migraine work on blood vessels, like beta blockers, calcium channel blockers, triptans, and ergotamine derivatives. Now, this idea was actually firmly codified by one of the founding fathers of modern headache, Harold Wolff. He was working in the 1920s, 30s, and 40s doing experiments on people that you really can't quite do these days. He had patients when they're going into the emergency room or going into surgery and was stimulating different blood vessels and actually different structures inside their head and provoking pain that was really quite reminiscent of migraine. So he found that if he poked around at some of the temporal arteries, he could really cause a pain like migraine. Additionally, if he poked around at structures deep inside the brain affecting the blood vessels, it would also cause a migraine-like pain event for these patients. But what was really interesting is he took 45 patients who were going into surgery for a brain tumor, and while they're awake, because the brain really doesn't sense a lot of stuff, you can wake people up, he would insert a balloon into one of the major blood vessels sitting across the top of the head and inflate it. That was very painful to these patients, and they reported that there was a lot of pain that was similar to migraine. What he ended up doing was measuring the pulsations of blood vessels on the side of the head, the temporal artery, and he gave these individuals a very potent vasoconstrictive medication called IV ergotamine that narrowed the blood vessels down, and he noted that, and he could measure that by measuring the amplitude of the pulsations. But coincidentally, their pain also significantly improved. So based upon that idea, we really developed the concept that blood vessels are the biggest driver of pain. But that was over almost 100 years ago. Our ideas of what's going on inside the brain have rapidly evolved, specifically in the last maybe 20 years, largely due to imaging. So PET imaging is largely what I'm going to be focusing in on for the rest of the talk, because that's informed our understanding of the biology of what's going on inside a migraine brain. What we did see in this study, this is done by a colleague of mine while I was working in London, Shazia Afridi, and she found that during a migraine event, a certain component of the brainstem, actually a small region called the trigeminal nucleus caudalis, was active in a migraine nerve. This is a spontaneous migraine that was occurring. Based upon work like this and other animal studies, we've learned that migraine is a very complicated process. There's so many different structures that are involved in the process of generating migraine pain and all the symptoms of migraine. And this is just kind of a brief summary of what's going on. I know this is a lot to look at, but we're going to take it apart piece by piece, because I think by understanding the biology of what's going on, this informs our ability to help make educated and informed decisions on how to help our patients, as well as in what medications might be beneficial for them. So one question that might really be beneficial that seems a little bit counterintuitive to ask is, when does a migraine start? Well, another colleague of mine, Nicola Griffin, she did a very interesting study. She gave a bunch of patients, 112 patients, Palm Pilots. Do you guys remember those? Yeah, I think they've gone long and extinct by now, but this is back in vogue when these were really, really handy. And she gave 112 patients Palm Pilots. Only 97 really were able to write everything down, but she wanted them to track out their symptoms of when they were experiencing something just funny happening and how that related to when their headache began. And she found that upwards of almost 2 days before a headache event started, people were noticing things were happening to them. They just didn't feel quite right. So the migraine actually doesn't begin when the pain begins. There's something deeper going on. The things that she was finding were tiredness, thirst, frequent urination, sensitivity to light, nausea, yawning, irritability, and other mood changes. This is all happening way before the pain ever initiated. It's kind of an interesting thing. Now, when you talk to people about what they think that kicks off their head pain, and I do this a lot, I do this every day, I hear about food triggers. A lot of people like to talk to me about how when I eat chocolate or drink wine or have coffee or artificial sweeteners kicks off their head pain. Well, somebody really thought about doing a more formalized study, Lou Kellman, back in 2007, and he really wanted to find out what was really helping to trigger off a migraine event. And it turned out that food was at the very bottom of the list. Much more interesting were stress, hormones, meal skipping, and sleep disturbance. Those were much more strongly provocative. Now, when we talk about that, they kind of seem like they're completely unrelated to each other. But it seems like there's actually one area of the brain that governs all of these functions. That's the hypothalamus. It's a very small little organ inside the brain, smaller than a pea. It's on both sides. And it's very tiny, but it involves so many different disparate functions inside the brain. It controls when you're hungry or you feel full, or when you menstruate or go through puberty, when you wake up, when you go to bed, when you feel stressed out, when you resolve from stress. What it essentially does is it balances very competing different ideas between sleep and arousal, stress and relaxation, hunger and satiety, and it keeps everything in check. But if one of these things gets off, that can set off the hypothalamus and cause other things to occur. What we think goes on, and we actually have very good and strong imaging evidence supporting this. This is a very recent study published by other colleagues of mine at UCSF, Farouk, in the Peter Goadsby lab, and they found that prior to the onset of the headache event, the hypothalamus, that's in the red, gets activated. And it turns out that this is a Denuel study. She's in France, and she found a very similar thing a couple years back, but this was during a headache event. We know that the hypothalamus, for some reason, somehow is very important in the initiation of a headache as well as the propagation of headache. Could we click back, please? Thank you. So what we think is that when the hypothalamus gets disturbed, it can send a signal to a cluster of nerves called the trigeminal cervical complex. When that gets activated, oh, dear me. Bear with me, sorry, we're having a couple technical difficulties.
Is this right off the internet? Or
Pardon me?
do you have this on the internet?
No, I think there's the system here is it keeps on when people are checking in.
Yeah, I've been at the website for more than once.
And so when it gets activated, it actually, when the trigeminal cervical complex or the trigeminal nucleus caudalis, I'm going to use the two terms interchangeably. When it gets activated, it can activate a group of nerves called the trigeminal nerves, one on each side of the face. And the trigeminal nerves provide sensory input to the face. The first division, the ophthalmic, largely innervates this part of the face. The maxillary innervates this little strip, and the mandibular innervates the lower jaw. Now, it seems as though that this first strip, the ophthalmic, is largely important in the generation of migraine pain, and it's for a variety of reasons, but we think mostly it's because of the distribution of certain receptors on them, called serotonin 5-HT1B and D receptors that seem to be more preferentially distributed on this branch as opposed to others, but that's a little bit more beyond than what we need to talk about today. The ophthalmic branch doesn't just innervate the skin and tissue of the face, it also innervates a thin layer of tissue surrounding the brain called the meninges. Now, this meninges, it stretches, it covers the entire brain, and this nerve just doesn't innervate just that, it stretches all the way to the back of the skull. And based upon work by Harold Wolff, he found that if you stimulate various areas of this meninges, you can also replicate migraine-like pain in people. So what we think is going on is that when this trigeminal nerve is activated, it seems to irritate meningeal blood vessels. What happens is that when it's stimulated, it releases certain chemicals, inflammatory chemicals like Cgrp, substance P, and neurokinin Y that can cause blood vessel dilatation. And this is an in vivo study looking at the inflammation process, and this is before the release of some of these inflammatory chemicals, and this is right after. This blood vessel dilatation then irritates other nerves and then sends a signal back to the trigeminal nucleus caudalis up through the periaqueductal gray to the thalamus, or the inner bed chamber. That's what the thalamus means. It's Greek for bed chamber. And then that sends it to various other areas inside the brain, loosely called the pain matrix. And that's where we begin to actually notice and be aware of what pain is. Now, that's not the only part about migraine that's going on. There's also another thing that's called classical migraine, visual aura. But it turns out visual aura, or aura, really doesn't occur in all that many people with migraine. It's only about, 18% of people, although it's called classical migraine. It's not the most common presentation of migraine. But what exactly is aura? Well, here's an example of someone's experience with aura. And hopefully this will work. So most people with migraine won't be wandering around their backyard, but this person was. And what you can kind of see very loosely is just a shimmering light that's gradually expanding across a visual field, followed by a dark spot in their vision. And the rate at which this expands is kind of an interesting rate. It's about at 3 millimeters per minute. And what we think is going on is something called cortical spreading depression. And Mazziota at UCLA, he was able to get a patient of his captured in a PET scanner during one of these visual aura events. And he's able to see a wave of electrical activity starting in one area of the brain, then gradually progressing out. And the rate at which it goes is roughly about 3 millimeters per minute as well. It's kind of interesting, and people have correlated this visual phenomena to this blood vessel phenomena, and this wave of activity that starts as an active wave followed by a region of decreased activity within the brain. So how does this play out in what we see? So we think that when this wave of activity spreads across the brain, it can activate certain parts and then cause decreased activity. When it hits the back part of the brain, it can cause a shimmering light. But as that wave moves on and then it leaves a spot that can't work so well, there's a spot in the vision. If it affects other areas, like the sensory strip, it can first cause a tingling sensation, then followed by a sensation of numbness. The tingling doesn't tend to actually start there. It's usually these three fingers and starts in the web, and usually the corner of the mouth, and then spreads up. Very rarely, this wave can actually hit the motor strip and cause something called hemiplegia, where parts of the body become weak. Now, very rarely as well, it can involve parts of the temporal lobe or the language area, and it can precipitate something that you guys might have seen.
This is what happened.
Well, a very, very heavy rotation tonight. We had a very Darrison, but let's go ahead, Terrace chases let's put it ahead of the pet.
Could you guys hear that? That's a very scary thing. Do you guys remember seeing this on TV? Well, the big worry was, gosh, this lady was having a stroke on TV. It turns out she wasn't. She was having a migraine, and she's allowed people to freely talk about this. I know the physician who takes care of her very well. And she was having a very typical migraine with aura event for her. Migraine with aura can cause all sorts of very weird and crazy things to people who just aren't really aware of what's happening. It can be exceedingly disturbing. But the very interesting thing is that this cortical wave of electrical activity happens in people who don't have aura. It happens in most people who actually have migraine. Now, there's probably some sort of genetic predisposition behind why people experience these transient neurologic deficits and why some people don't. We haven't fully ironed that out yet, but we do know that cortical spreading depression happens in almost most people with migraine. Now, we've had some very interesting ways of measuring this level of activity of the outer layer of the brain. We use something called visual evoked potentials. This is a much older study done in the 90s before PET imaging was really widely available. But what it does is you flash a checkerboard pattern and then you measure the electrical activity generated by that flashing checkerboard pattern, and then you measure the delay that it takes. In people who don't have migraine, you flash this pattern at them, and then they do something, they habituate to this, meaning their amplitudes of this waveform decreases over time. So people who don't have migraine, they just get used to it and it doesn't really do anything. People who do have migraine, on the other hand, they actually start responding more and more and more. That's kind of strange. That might help explain why people with migraine are a lot more sensitive to light, to sound, to smell, to movement than people who don't have migraine, even outside of the migraine event. Now, another very interesting study done a few years later was by Stefan Edwards' group, and it's a little complicated of a slide to see, but this is looking at that habituation. And it turns out that right before a migraine event occurs, which is represented by the lightning bolt, that the most impaired habituation can occur just right before, but during a migraine event, people's habituation levels return back to normal to what a healthy person's brain is like. So one way about thinking about this is maybe a migraine event is like hitting the hard reset button of a brain. We don't quite know, but that could be an adaptive thing. We know that there are a lot of genes involved. This is just a brief summary of some of the genes that we think are distinctly involved within making migraine a lot more common. But there are likely hundreds, if not thousands, of genes, and that kind of implies why migraine is such a challenging thing to treat, because not everyone's going to respond to the exact same things. We know about other regions of the brain based upon imaging studies. Unfortunately, not all of my images are coming out, but we know that different regions of the cortex, the occipital cortex or the temporal lobes, can be involved in hypersensitivity to light and to smells, and nausea. You can get the locus coeruleus and parts of the brainstem activated, or the periaqueductal gray and parts of the hypothalamus as well. Other symptoms like neck pain and neck stiffness are a ubiquitous sensation of migraine, but people don't always put that together. Oftentimes, they think that their neck is causing their pain. So one study attempted to address this and find out about the frequency with which people have neck pain and migraine. And they looked at 412 patients, and all of them had been vetted by headache specialists, and they've been discerned to have had migraine. But nearly 90% of these people experienced one or more symptoms of stiffness in their neck and back pain, tenderness in their neck muscles. Seems a little strange. Why would this happen in migraine? Well, the anatomy informs us of why this might be occurring. When the hypothalamus gets activated, it again can activate the trigeminal cervical complex, but it just doesn't live in the brainstem. It dips down to the upper levels of the spinal cord. It can then activate nerves that innervate the back of the head and innervate the muscles and trapezius, the occipitalis and the trapezius muscles. So in a way, we kind of think about this as referred pain. We've all heard about when people have heart attacks, they get pain going down their arm, and we don't think there's anything wrong with their arm. It's just the way that the body's hardwired. Well, in people who have migraine, they oftentimes get neck pain and neck stiffness before the onset of their migraine event. And Bob Kanicki, he did another follow-up study looking at 144 patients and found that 75% reported neck pain and neck stiffness before or during their headache event. And he imaged these patients, and these people didn't have anything wrong with their neck whatsoever. Now, another common thing that I see is people believing that they have sinus headache. And another group, they really wanted to look at the association between sinus symptoms and migraine. And they looked at 2,400 patients, all who had been vetted by headache specialists, all who had been diagnosed as having migraine. And these individuals, they were reporting up 85% almost had sinus pressure, 82% had sinus pain, 63% had nasal congestion, runny nose, watery eyes, itchy noses. These are all symptoms that we commonly associate with a sinus headache, but these were happening during migraine. And we think about why this is going on. Again, the anatomy clues us in. When the hypothalamus gets activated, it can send a signal down through the periaqueductal gray and activate a small nucleus called the superior salivatory nucleus. Now, this little area of the brain, it helps govern certain features of our body that account for the autonomic nervous system. We've all heard about the fight or flight response, right? That is the sympathetic nervous system. So when something stressful is happening, your heart rate goes up. But there's also the rest and digest system, the parasympathetic system. That's what this governs. So when you're eating or relaxing, your blood vessels dilate, you salivate more, your glands can get more swollen. Well, when this gets activated, it talks to this phenopalatine ganglion that provides innervation to the sinuses and then can cause swelling and account for a lot of these symptoms. Now, really to hammer home that point, Chris Schreiber, what he did is he took a patient who was known to have migraine and stuck an endoscope up his nose outside of a migraine. And you can see this is his turbinates, and they look, what I guess a turbinate normally looks like, pink and non-swollen. Then he looked at them during a severe, quote, sinus headache, and you can clearly see the difference. It's swollen and inflamed. Then he gave this patient a medication that treats only migraine. It doesn't treat sinuses, it treats only migraine, and there's the beginnings of resolution of this inflammation. We really strongly think that this idea of sinus headache is a bit of a misnomer. If we really want to attribute a sinus infection to causing head pain, we should look at the ENT criteria. So according to the ENT criteria for sinus infections, fever has to be present. And most people with migraine, when they're having their symptoms, they don't have a fever. They don't have stuff coming out of their nose, like a purulent discharge. It turns out that headache is at the very minor feature. of this event. Unfortunately, this idea of sinus headache has been propagated by a manufacturer in the 1950s, and this has sold a heck of a lot of product over time. In fact, we don't have this term in other parts of the world. It exists here in America because it sells a lot of things. But this is kind of a nice segue into how do we go about managing headache? Well, in my practice, I really like to try to focus in on lifestyle modifications like eating at the same time, exercising 30 to 40 minutes a day, decreasing your caffeine intake, drinking water, getting on a very regular sleep schedule. It sounds like this is great grandmother advice that we've all heard, you need to do this, but the big reason is that the idea is to push your hypothalamus into better function. You need to regulate your hypothalamic activity that might be able to override its ability to activate. In some people, this can be really quite helpful to do. In other people, we need to do other things, like provide acute care. And to understand a little bit why some of these medications are helpful or not so helpful, the anatomy comes in pretty handy. So one of the things that people use a lot are anti-inflammatory medications, non-steroidal anti-inflammatory drugs, like ibuprofen, naproxen, aspirin. And we think that the main reason why they work is that they block the activity of inflammatory chemicals. They don't allow the blood vessels to get swollen up because they block the nitric oxide synthetase and other inflammatory reactions that can occur that would then thereby irritate this pathway. Turns out that they might actually have some activity inside the brainstem as well as the hypothalamus, but that's still being worked out. We don't really have all the details yet on that. And these can be really helpful in some people. Now, in other patients that I see, I really try to go to triptans. And triptans, you might have heard of sumatriptan or Imitrex, rizatriptan, Maxalt. There's a whole host of them, and this is the first, and this is this is the most recent. And they come in various different delivery systems. Some are oral tablets, some are injections, some are patches. Actually, the patch just got taken off the market earlier this year. But some are oral films. And we think that they work by not only blocking the release of these inflammatory chemicals from the nerve, but blocking the blood vessel's ability to respond to those inflammatory chemicals, as well as blocking the transmission pathway of that electrical signal from the nerve upwards. These can be remarkably helpful lines of care, but they have to be taken at the immediate onset of the pain. If you've taken it far too late into a headache event, there's already plenty of inflammation there, so you might be transiently stopping this process. But when this drug wears off, anywhere from about 6 to 12 hours, this inflammation is still there and regenerates this migraine-like pathway. So sometimes what I do in patients is I combine triptans in addition to anti-inflammatory medications to really provide a 1-2 punch. Now, for nausea, oftentimes if you use the right acute care, like a triptan, you can stop the nausea event. But some individuals, we do need to step it up and use medications like metoclopramide or promethazine or ondansetron. And they work in various areas by blocking the signals of nausea, either in the brainstem or how the hypothalamus can respond to those nausea signals. Now, there are a number of other lines of care that can be used, that are commonly used, but I really try to avoid them in my clinical practice. These are mainly opiates or narcotic-based medications, butalbital and Tylenol. Because sometimes in certain situations, these can actually cause a lot more headache than they can help. It turns out that if you use an opiate more than 7 days a month, a butalbital-containing product like Fioricet or Fiorinol more than 5 days a month, or a product containing Tylenol more than 15 days a month, you can take somebody who has an episodic headache disorder and turn them into chronic migraine. That's a very tough problem. That actually represents about 60–80% of the patients that I see in my practice. This is a very common problem. 1.5%, or actually 1.4% of the population is suffering with medication overuse headache. This is what I deal with every day. This is a very, very common problem. What we think is going on, or at least with opiates, is that this can activate certain cells inside the brainstem. Not the nerve cells, but the supporting cells called glial cells. That's Greek for glue. These glue cells were thought to do nothing but provide architecture for nerves to hang on to. But it turns out there's been more research demonstrating that these cells, when they're exposed to opiates, they bind to receptors, toll-like receptor 2 and 4, and that can cause a release of inflammatory chemicals, causing a localized inflammation, stoking this process, and thereby generating pain on its own and causing daily headache. So in my practice, I really try to get people off of opiates and butalbital-containing products. I'm a little bit more liberal with acetaminophen products, but I just don't see it all that often. But one of the big confounders here is Excedrin, which is not just acetaminophen, but it's caffeine too, and that has its own issues. But we can talk about that too. Now, we have very supportive imaging evidence demonstrating that certain regions of the brain actually become less active when they're exposed to these opiates or these barbiturates. But it turns out the good news is that if you can stop this, over time, all of these regions of change go back to normal, or most of them do. So this is a reversible process. When it comes to preventing headache, there are a whole lot of options available, and this is just a summary of the guidelines produced by the American Academy of Neurology. Most of the medications we use are borrowed from other areas of medicine, like blood pressure medications or antidepressants, anti-epilepsy medications, and they're not really designed for migraine in and of themselves. So they have their pluses, they have their minuses, they have their side effects, but they're not really intended for the sheer management of migraine alone, and we don't really know exactly why or how they work. We do have some evidence that some medications, they can actually block that electrical activity in the brain. So it makes sense for the anti-epilepsy medications like topiramate or valproic acid, but beta blockers and tricyclics can also stop this. We don't know how or why, but we do know that these are effective medications. Well, we've been trying to get a little bit more specific on lines of care, and in the last few years, we've really been tailoring preventive lines of care a little bit more finely. So one line of care we've been really focused in on is blocking the activity of calcitonin gene-related peptide, Cgrp. And it turns out that Botox does this. Yeah, it's kind of interesting. You give somebody 31 injections every 3 months, and seemingly in some individuals, they can respond well. I think the data is a little bit misleading. It does help some people. It can be beneficial. It's not the primary backbone of what I use in my practice, but I do use this for some individuals because it can be rather helpful. And the idea is that it blocks the release of this Cgrp, but it does wear off every 3 months. Now, I also am really intrigued about this new line of care, and in fact, I'm not the only one. There are 4 companies looking at creating these antibodies to Cgrp, and we think that it not only works peripherally, but it blocks the activity of Cgrp within the brain. And so far, these 4 companies are all vying to become the first one to market, and their studies look exceedingly promising. And the side effect profile is minimal, just an injection site reaction, and you get an injection once a month or an infusion once every 3 months. And you do the injection at home. It's a quick thing to do. You don't have to go to the doctor. It could be a very revolutionary way of treating care. It's going to be expensive, though. That's going to be the big challenge. This is not going to be a cheap line of care. Now, we have been investigating doing stimulation, using the occipital nerve as a backdoor entry point to modulate this trigeminal cervical complex. And for the last decade and a half, there have been different studies using occipital nerve stimulators to shut off this pain pathway. And it's actually been rather helpful in some settings. Unfortunately, it hasn't really been FDA approved because a lot of the studies have been confounded by the fact that these electrical leads that are put in over these occipital nerves aren't designed to be there. They're more designed to be in the lower back or the leg or somewhere else, and they get pulled out, they get infected. There's a lot of complications that occur that's really made a lot of these studies not all that great. So I think in the next few years, we're going to be seeing a new generation of stimulators really going after this. Maybe that don't require such extensive surgery either. Now, you guys might have also heard of this device. Has anybody? Yeah, has anybody bought one? Anybody tried it on? Well, I mean, it did get FDA approved based upon a very small study in Europe and a small study here in the States. And I've had patients describe that it feels like a woodpecker on their forehead. If I had migraine, that wouldn't be a really pleasurable thing for me by any means. And I know of many centers that actually collect these from their patients and then return them back to the manufacturer. This is not a line of care that seems to be overwhelmingly effective for everyone, but there are some individuals who it might really be helpful for. But this is an out-of-pocket expense, it's not covered by insurance, and so I don't tend to use this in my practice. But some people do get benefit with it. I just haven't seen anyone yet. Now, there's another very interesting line of care using transcranial magnetic stimulation. And what this is, it is an electromagnetic pulse that is applied either preventatively or acutely. It's only FDA approved for migraine with aura acutely to terminate one of these waves of electrical activity. And it seems to be rather helpful for that. But people have been applying this for people who don't have migraine with aura. This is all off-label, and so far it's seemingly pretty helpful. Unfortunately, again, this is not covered by insurance programs, and this is a pretty hefty cost to pay, but it can be remarkably helpful and doesn't have really any side effects or any of the effects or hassles of having to take a daily tablet. Now, there's another line of care that is currently being developed right now. It's FDA, or it's a CE approved in Europe, but not yet here for a certain type of headache disorder. It's called a Finos Palatine Ganglion Stimulator. And it works by electrically stimulating the sphenopalatine ganglion, and it can help shut off activity of certain types of headache disorders, like cluster headache. It seems to be remarkably helpful for a very rare headache disorder, but it might also have implications in being helpful for migraine too. Now, there's another line of care using another backdoor entry point into this migraine process by stimulating the vestibular cochlear nerve. And it's these headphones you put in, and it flushes cold and heat inside the inner ear. And early studies seem to show that it might be rather helpful. I don't know what the long-term data is going to be on this. And yet, even another backdoor entry is by the vagus nerve, by affecting that autonomic nervous system. You can apply stimulation to this and acutely abort a headache event. This is still in early phase studies, but it might also be a non-invasive, non-medication way to help people with migraine. So I know we kind of went through a lot of stuff, and this is just a nice summary slide to kind of review what we had just talked about. So in the beginning stages of migraine, people experience the premonitory symptoms of yawning, increased urination, neck pain, and fatigue. And there are various areas of the brain that get involved, like the hypothalamus, brainstem, and cortex. Sometimes this is followed by an aura, which can be a visual or sensory or cognitive or language deficit, and that's also mitigated or managed by the cortex. Then it's followed by head pain. Sometimes the aura happens on its own without any head pain. Sometimes the aura happens during the headache event. But we know that the head pain itself is managed by the brainstem, thalamus, hypothalamus, and cortex. I think where our attention is really going to be focused in on is in this postdrome, or the resolution phase. We don't know why that happens. We don't know what parts of the brain are causing this to occur. But I think as clinical scientists, we're really interested in being able to push a brain into that state, and we need to learn about this more, and to do this without really using all sorts of medications that aren't really designed for treating migraine. Hopefully, we will have new lines of care available within the next few years that can really just address this aspect in pushing people into resolution. Well, thank you so much for your attention. I'm happy to take any questions.
Can we start with our remote sites? Are there any questions from the remote sites?
Yes, sir.
From the beginning of your presentation, it appears that if you have 1 in 4 households, that the percentages would make it appear that it's a family thing.
Right.
It's very hereditary. Is it?
Absolutely, without a doubt, there's a genetic component.
All right.
For the vast majority of people, there is a heritable aspect behind it. So you may not like if you have migraine, you may not know that your father had migraine, right, and he could have outgrown this, because men tend to usually outgrow it by the time they get to puberty and forgotten that they had migraine. You could have inherited those genes and not be able to elicit that history from your family member.
You said 1 in 4 families, and the highest number I think was 16% for certain women.
Yeah, well, I think those numbers are awfully conservative.
Well, yeah, but that would eat up the quarter right there.
Yeah, I think
so
migraine.
There must be 3 out of 4 families never experienced this at all. You know.
Well, I think that the numbers are a little bit misleading in some regard when you parse it out like that. I think that everybody in the world can experience a migraine event. You just have to stress them out hard enough. You have to expose them to a bright enough stimulation, or to give them alcohol. A hangover is a migraine event. Or you have to do something to them to provoke them hard enough. Migraine is a ubiquitous human experience, but there's some people who experience migraine a lot more frequently than other people do. a lot more, and their threshold to having one is a lot lower. So maybe just missing a meal will kick them off into a headache, whereas it might take somebody else who doesn't experience migraine very frequently, you have to deprive them of food for days on end. But I think this is a threshold thing, and I think these numbers are a little bit arbitrary, and I wouldn't be hanging my hat on them specifically. It's just to give a rounded idea of the prevalence of the disorder, if that makes sense.
I have kind of a random question. Is there a physiologic explanation as to why after a migraine event you can feel kind of, we call it like you've been beat up,
Yeah.
just feeling awful
Right.
afterwards?
Well, I think part of this is that you are having a whole brain discharge. So many different areas of the brain are getting activated and overrun. They're just not able to function quite normally. It does take time for them to recover. Some people who've got chronic migraine, that's just how they feel all the time. It's a miserable state. It's horrific. And fortunately, though, we are trying to find ways to just terminate the attack much more quickly so that all these brain processes don't get so involved so early on and they don't have that hangover effect.
Thank you. Can acupressure help during the migraine attack?
Well, acupuncture has been studied quite a lot, not so much acupressure. And it seems as though acupuncture can be helpful for terminating a headache attack, but it doesn't seem to be helpful in long term. So they've done placebo-controlled sham studies where they just use the pressure versus the puncture, and it turns out there's really no difference in chronic migraine. But episodic migraine, it can be helpful. Why? We're not really quite certain how or why. Maybe it's through the activation of adenosine receptors, similar to how caffeine might work. Maybe, maybe not. Don't know. Yes, ma'am.
Is there a psychosomatic correlation with migraines? Unless they're tested, do you truly know if these people are having a migraine? Or is it more of a mental?
Well, I think that the question that you're getting at is, I'm going to answer it in a slightly different way. We do know that in a migraine event, various areas of the brain get activated. One of the pain areas that can get secondary pain processing areas inside the brain is the insular cortex. And that's where mood can be processed as well. So you can see a lot of anxiety and depression getting activated in a migraine event and afterwards. And if you have chronic migraine, you can get more anxiety. And actually, if you have more anxiety, that can drive secondary sensitization and you can start experiencing more pain. Or if you have more depression, you can have more pain. Causative, though, I wouldn't use the term psychosomatic because I think almost everybody coming to see me has a problem and they are experiencing head pain. And you're right, we don't have great objective measures. I don't have a blood test that I can say, gosh, this is what's I can measure this objectively. So you do have to rely upon the symptoms that they're having. But if you really talk to migraine patients, they have a very, very particular constellation of symptoms that are stereotyped for that individual and that are verifiable by the anatomy. So I don't use the term psychosomatic. I do believe that mood can distinctly influence headache, and headache can distinctly influence mood. But I have yet to see somebody who's coming into my office for a secondary gain issue. Maybe they have other mood-related disturbances that also need to be addressed, but I really try to focus in on their head pain. Sure.
You mentioned Excedrin earlier.
Yeah.
Well, is it bad?
Yes. No, actually, I like Excedrin. I think it works remarkably well for people who have episodic migraine. If it works for you, fantastic. I get concerned if you're having to turn to it more than 2 to 3 days a week. Then it may not be the best line of care. If you're using it that frequently, gosh, it might be helping to drive some of your pain. And maybe there are better options available to help stop the attack. Because a lot of people, when I use a daily, or when I use an acute care medication, I want a drug that's going to stop the pain within an hour, completely, no residual pain, and it stays gone for at least a day. That's what I call a success. That's what I want patients to have. A lot of people who use Excedrin, it brings it down to a tolerable level. They can get on and do stuff, but it doesn't render them free. So I don't know if that answers your question. It can work remarkably well. Actually, I use a lot of aspirin in my office. A lot. I use Alka-Seltzer Extra Strength quite a lot because 650 milligrams of aspirin, that works really, really well. There's some studies that IV aspirin, 1 gram, works as well as injectable sumatriptan. but it's hard to get an IV aspirin, so we try to use the gut as best as possible. That can really be tough on the stomach, though.
Is there a certain frequency of migraines that you recommend that maybe people have before they come see someone like a specialist?
Well, I usually put it down, not necessarily frequency, but how much it's impacting their life. There could be somebody who has just one attack every couple of months, but when they have an attack, it devastates them for days. That's affecting their life. They can't go to work for a few days. That's impairing their life, or they can't do things. I don't put it down to a frequency, but I put it down to how much disability it's causing. So if it's something to the point where they're taking things frequently, sure. So a rough rule of thumb is when I start a daily preventive medication, if they're having 4 or more headache days a month. That's when I start thinking about a daily medication to help people. But I don't always do that. I try to work it out with what patients are doing in their lives. Sometimes just lifestyle modification alone can help out, like getting people to sleep regularly. People don't appreciate the importance of sleep. Sleep is critical, and we take it for granted. We don't get routine sleep. And I think that's, we don't also exercise. That's a very, very big deal. We've got very strong evidence demonstrating that routine physical activity, gosh, 30 to 40 minutes a day, every day, can be as good as taking an oral medication. But who here does 30 to 40 minutes a day? Not too many of us. You might, but, but it's really important. Yes, sir.
There's I just heard on the KNPR about acetaminophen.
Yeah.
It's coming out with, could be a cause of ADHD, is that right? And pregnant women for their children later in life to be very overactive.
You know, I'm not as.
I thought Tylenol was a very safe product as long as you didn't take too much of it.
Yeah, and that's still kind of one of the things that we think is maybe it isn't so safe, but it is recommended, or it is recommended to be safe in the setting of pregnancy. I just don't know enough about the research done to comment adequately on the presence of ADHD with Tylenol.
You'll probably read about it soon.
Fair enough. You're more informed than I am. Yes, ma'am.
Do marijuana chemicals work on your patients?
Well, it depends upon who you talk to and for what they're using it. Now, there have been some longer-term studies looking at the utilization of marijuana for headache and for episodic headache. Maybe. What it seems to do is it doesn't actually address the pain, but it seems to make you care a little less about the pain. It can also help out. Yeah, it can also help out with nausea too. But one of the downsides is that very frequent usage of this can actually cause more migraine. But the challenge is the studies done on cannabinoids are so disparate because what you're getting from one supplier, you're getting a different THC content from another supplier. And you can't really control. That's the active psychoactive substance, and you can't really control for that from one place to another. I have patients who I don't advocate this, but they use marijuana, once every couple of months, and fine. I don't really. It doesn't affect me that much. But if they're using it consistently 2 to 3 days a week, that can actually cause a lot more migraine. We've got some evidence demonstrating it causes not only migraine but other brain changes. And frequent marijuana usage may not be a great thing at all. But if it's for every so often for the nausea or to help you not care so much about the pain, fine. Do what you need to do. But frequent usage, probably not the best thing.
Well, you're one of the few guys that can prescribe it, and people are desperate for help.
Yeah, well, the evidence isn't really very provocative for me yet on the benefits of it in the setting of headache. And that's all I take care of. I just take care of a small subsection. And so far the data that we have right now, and a lot of it's actually being organized by Brian McGeaney out of BU. And so far the summary evidence just isn't helpful. It may be helpful for other issues like in multiple sclerosis and dealing with some aspects or dealing with nausea. That's great. But for the head pain in and of itself, could be helpful for the one-off. But frequent usage, it seems to be more harmful and causing more headache in the long run. I actually have seen a number of adolescents who have been using marijuana quite frequently, and it can cause a very difficult to treat headache disorder. They're very married to the idea of staying on daily marijuana, and it's hard to break them away. not quite the answer you're thinking. I'm sorry.
I don't have any prejudice one way or the other, but I think there should be more studies
Sure.
and better studies
Yeah.
because I think the old studies didn't have enough subjects.
Well, I think you're absolutely right. There does need to be more research done. One of the biggest challenges that we're facing is the NINDS, which is the national, I forget what the acronym stands for, but it's with the NIH branch dealing with neurologic disorders. They do not fund headache research. They do not as a blanket statement. And it's really, really unfortunate. It is very hard to get good basic science research done. And we are using our resources, our patient population resources, to help us advocate quite strongly. If you're interested in helping to drive more research forward, you can visit the website of the American Migraine Foundation and help donate or find other ways in which you can contact our congresspeople, our statesmen, to help advocate for us to get more money for this problem. This is a very common problem, yet the research dollars are inadequate. So let's put this in comparison. Vulvodynia, who's ever heard of that? There's 10 times the amount of money going to the study of vulvodynia than there is for migraine. Vulvodynia affects a very, very fraction of Americans. Migraine is a disabling thing. It is causing so much money to be lost. It's causing so much disability, yet the funding for research doesn't exist. So I agree with you. More research does need to be done, and adequate research. We're just not being able to attract the best minds to being able to do this
Well,
yet.
you're ideally located because marijuana is legal here and we have stores full of it.
Yeah. Good point. Well, thank you all so much for your attention. I really appreciate the opportunity to speak here, and thank you for inviting me to speak.